quickly. The picture in the New England Journal from last week concerned this 49-year-old man, 3-month history of illness. He's hoarse, so this must be laryngoscopy here. He has a history of type 2 diabetes and he's a smoker. And we have 5 things that were offered here. Vocal cord granuloma isn't given. Commonly these go concomitantly, but this is a cancer with ulceration, and actually it looks like purulent material here, and that would explain the hoarseness. These other conditions could also cause hoarseness, but okay. The first paper in the New England Journal had a series of papers on HIV treatment. And one of the drugs that's been introduced lately since resistance to current medications is developing is a drug that interferes with integration of the transcribed retroviral genome into the human genome. So dolutegravir is a viral integrase inhibitor, and it has this structure, reminds me of tetracycline. And this drug has now been introduced for the treatment of HIV. Now, reverse-transcriptase is the enzyme that's necessary to convert the HIV viral genome into DNA, from RNA into DNA, so that it can then be incorporated into the human genome. And inhibitors of reverse-transcriptase have transformed, obviously, the treatment of HIV. And the most common one employed today is tenofovir. And tenofovir is actually a prodrug. There are several prodrugs to this material, and they're also a topic of these papers that I'm going to show you. And the standard reverse-transcriptase inhibitor is efavirenz, and since resistance is developing against efavirenz, the integrase inhibitor has been introduced. So these studies were, and the first study concerns is dolutegravir plus tenofovir as good as the standard treatment, which is tenofovir plus efavirenz. And there are 3 groups here involving the 2 prodrugs to tenofovir and the standard care group with efavirenz. And the endpoint here was efficacy at 48 weeks. That has to do with RNA copies of HIV and safety data. So in this first study, what was basically shown here is that the new combinations are at least no worse than the old combination. And HIV RNA suppression was actually met goals at weeks 48. And the primary side effect of dolutegravir was weight gain, which in some subjects was substantial. I've had to abbreviate some of these reports. The second trial was also performed in Africa and Cameroon, and here dolutegravir-based therapy was compared to efavirenz-based regimen for the treatment of HIV. This is genotype number 1, which is the more common genotype. And the primary endpoint was the proportion of participants with a viral load of less than 50 copies. And this aim was met, and the new regimen again was no worse than the old regimen. So this all sounds wonderful, except there's one fly in the ointment. It's been rumored that spina bifida or neural tube defects could be more common in patients getting this new drug, the integrase inhibitor dolutegravir. So a third study was performed, and how this was done you can read on your own in greater detail, to see whether or not neural tube defects are indeed more common with dolutegravir compared to the neural tube defects that occur spontaneously, or neural tube defects that occur in women that are HIV positive, that are taking the older regimens for HIV. And basically what was shown in this study was they were a bit more common, but the spontaneous appearance of neural tube defects was 1 in 1,000 births. And the appearance of neural tube defects, spina bifida syndromes, in women, HIV-positive women taking dolutegravir was 3 in 1,000 births. So indeed, that is more common, perhaps even 200% more common. But the question is, how relevant is this problem with a background of being HIV positive? Now, all the women in this study received prophylaxis against neural tube defects with folic acid. Whether or not very large doses of folic acid might have decreased the appearance of neural tube defects in the dolutegravir group cannot be answered from this study. So dolutegravir is effective. It seems to be an improvement over previous treatments. There is some increase in neural tube defects, but the increase in neural tube defects, in my opinion, is relatively modest. The next topic in the New England Journal was concerns incretin mimetics, and we've discussed these already. These are agonists of the GLP-1 receptor, and these incretins result in an increase in insulin release, a decrease in glucagon release. They appear to preserve pancreatic function so that apoptosis of islet cells is diminished. They appear to increase insulin sensitivity and look like a very promising treatment for type 2 diabetes mellitus. Now, the incretins are catabolized by DPP4, an enzyme called DPP4. We also have available DPP4 inhibitors, although that's not the topic of the current study. Now, incretins have to be given by injection, which is perhaps a problem in some patients, although compounds have been developed that you only have to inject once a week. In this study in the New England Journal, there's an oral incretin mimetic, semaglutide, and the idea is that semaglutide could have efficacy similar to IV GLP-1 agonists. Now, the first thing that the company has to do is to show that oral semaglutide does not increase cardiovascular events. This requirement was initiated when PPAR gamma agonists were introduced that actually increased cardiovascular events or appeared to do so. So the first thing the company has to do is to show that oral semaglutide does not increase cardiovascular events. I'm aware of the fact that we would expect the drug to decrease cardiovascular events since other incretin mimetics have been shown to do that. So in this particular study, patients with type 2 diabetes mellitus that had a high risk for cardiovascular disease, or relatively high risk, were randomized to oral semaglutide or placebo on top of everything else that physicians currently give for type 2 diabetes mellitus, mostly metformin, some sulfonylureas, and some other compounds. So these were distributed similarly in both groups. So here are the patients, 1,500 in each group, and cardiovascular risk factors, yes. LDL cholesterol was fairly well controlled in these patients that were receiving statin therapy. Estimated GFR was pretty much normal. And what we see here is the patients were randomized to receive semaglutide at 3. That was increased to 7 milligrams per day and then 14 milligrams per day for the duration of the study, or placebo tablets on top of everything else that people get for type 2 diabetes. Now, the real world is on the bottom here, but we can expand these scales, and that was done in this graph. And what we see here is that the composite cardiovascular events, if anything, were higher in the placebo group than in the oral semaglutide group, although that difference was not statistically significant. What we see here is death from cardiovascular causes if we look at this hazard ratio, they were decreased by 50% in the group getting the oral semaglutide. So we had no reason to believe that semaglutide would increase cardiovascular events. So the company producing this material can be happy about that. Now what we see here is that glycated hemoglobin in these patients that were already receiving other treatments for type 2 diabetes substantially improved in the oral semaglutide group, dropped at least 1%. And what's also desirable is that the people getting semaglutide lost 4 kilograms in body weight, which I think is quite impressive. So it looks like semaglutide is going to be a good deal and can be taken orally. Now, the review in the New England Journal last week was adrenal crisis. This condition is fairly common. And basically what the author indicates here is people with adrenal crisis feel bad in a relatively non-specific way. If the problem is adrenal gland failure, then hyperpigmentation, pyrexia, and these hypotension because of volume depletion and these features are more common. But the problem can reside in the pituitary gland, and then the differential diagnosis is more complicated. Now, the biochemical abnormalities, particularly for adrenal cortical failure, are hyponatremia, hyperkalemia, hypercalcemia, hypoglycemia, and hypereosinophilia. Clinicians should know that. So that's reviewed for you here. What most clinicians don't appreciate is that cortisol has a circulating half-life of only 90 minutes. That means that people that are cortisol dependent, for whatever reason, can develop adrenal crisis in a very short period of time, since the hormone only has a half-life of 90 minutes. What's also apparent, and what clinicians should know, is that cortisol deficiency results in altered immune cell populations. That's why these patients get eosinophilia, for example, and that's reviewed here. Now, the treatment is hydrocortisone for adults and children. Hydrocortisone and volume expansion, fluid administration, volume expansion. That means a balanced electrolyte solution, not 5% glucose infusions. That's all reviewed here. And preventative strategies, which clinicians should know, particularly people that are under particular stress, or people that have been given corticosteroids that have discontinued them for some reason or other, are at risk for developing adrenal crisis. Now, the patient in last week's New England Journal concerns a young 16-year-old girl with head trauma, not very severe head trauma. She was on a team boat, and there was an accident, and the boom of the team boat banged her on the head, and she reportedly lost consciousness for several minutes. This business about reportedly is a problem for clinicians, because even if witnesses are present, they seldom look at their watches, and several minutes when people are in panic is a fairly rough estimate of the time differential that actually occurred. So historical information here is difficult. But this young lady woke up, felt a little dizzy, was a little unstable, had a normal neurological examination. Someone made x-rays of her cervical spine. We used to do skull films. Those were also worthless. And then she was sent home, which I would have done also, incidentally. But 11 days later, she comes back with rather vague complaints, claims that she's had spontaneous nosebleeds, and claims that she also had clear fluid emanating from her nose. That's a problem, because that might suggest that she had some sort of a skull fracture involving the cribriform plate underneath the frontal lobes, which results in a nasal discharge that is clear. What we used to do years ago is check this nasal discharge for glucose concentrations, because snot has a glucose of 0, and cerebrospinal fluid has a different glucose concentration. But at any rate, the clinicians were not in a position to do this because all of this was historical information. So that's the discussion here. How do you deal with this situation? So what was eventually done with this young lady is a complicated neuroimaging studies were done with CT, etc. These were all negative. And then, is this some sort of post-traumatic stress syndrome? And a big psychological discussion resulted in this case report in the New England Journal. And finally, this poor young girl receives a diagnosis of ADHS. Complicated discussion. Now we'll move over to the Lancet, and the first paper that I wanted to show you again was, which I finally had access to thanks to Annette Fibela, is this Polypill study that was reported in the Lancet 2 weeks ago from Iran. Now what was done in this study is that patients aged 40 to 75 years were randomized to treatment with the polypill or placebo tablets. Now, what these Iranian investigators did is they didn't randomize individual patients, they randomized Iranian villages to either verum treatment or nothing. And these tablets contained 12.5 milligrams of hydrochlorothiazide, low-dose aspirin, low-dose atorvastatin, and low-dose enalapril. If the patients developed cough, they were given a polypill that had valsartan, AT1 receptor blocker, instead of enalapril. Now, what bothers me about this study is I think hydrochlorothiazide should not be tried. Chlorothalidone is a much better thiazide-like diuretic and is the drug that was applied in all the clinical trials indicating the efficacy of this treatment, but that's what the investigators chose. In any event, here's the rundown on how this study proceeded that was conducted over a number of years. And here we look at the participants, men and women, and age between 40 to 75, and what their cholesterol levels was, and smoking yes or no, and whether they were Turkmenish in background or not, and their LDL cholesterol levels that really don't look so bad, and their blood pressure values. And basically what happened here is there was a statistically significant decrease in the polypill group in terms of fatal ischemic heart disease and also non-fatal ischemic heart disease, and both of those endpoints were statistically significant. Now, what bothered me a little bit is that the blood pressure changes are not statistically significant, and that's probably related to the fact that this polypill contained hydrochlorothiazide instead of chlorothalidone, in my opinion. But the decrease in LDL cholesterol was statistically significant. So that's the story on that study. Now, the next study in the Lancet concerned severe pneumonia in African children that were not HIV positive. And the investigators were interested in what's the etiology of severe pneumonias. These children were worked up in great detail with blood cultures and sputum cultures and polymerase chain reaction, and also looking for respiratory syncytial virus, parainfluenza, a whole host of viruses. And what the investigators wanted to know is, are the causes of pneumonia in young children in Africa any different than what we would expect, or do the usual suspects show up here? And indeed, the usual suspects showed up. Pneumococcal pneumonia, Haemophilus influenzae, the viral distribution wasn't so much different than what we see in North America or Europe. So from a policy perspective, the number of pathogens who were identified was relatively low. They were common pathogens, suggesting that vaccination against pneumococci and Haemophilus influenzae would be of value. And those are the important items in this study. Now, what the British also did in the Lancet was that they compared the results of knee replacements, patients were randomized to receive either a partial knee replacement, simpler operative procedure, or a total knee replacement, which some surgeons might favor because it's easier to do than to pay attention to the surgical care involved in a partial knee replacement. I'm not certain whether or not the remuneration is different in either one of these procedures. At any rate, the patients were randomized to partial knee replacement or complete knee replacement. And what we see is that the people that got the partial knee replacement did as well as the patients that got a total knee replacement. So that's something to consider if you have knee pain and someone suggests that you should have your knee joint replaced. So a more conservative approach seems to have the same efficacy as a more generalized total knee replacement. Now, the next topic at the Lancet concerns migraine headache, as you can see from this slide showing the calcitonin gene-related peptide. And this is an inhibitor of the calcitonin gene-related peptide. Calcitonin gene-related peptide is a peptide that has major vasodilatory features. And vasodilation is implicated in the development of migraine headache. So this drug to antagonize calcitonin gene-related peptide might be of efficacy. So that hypothesis was tested in these migraine patients, and it looks like the calcitonin gene-related peptide inhibitor was a little better than the patients that received standard treatment for migraine headache. So that was the basis of that report. Now the case report in the Lancet concerned this poor young man that got a cardiac defibrillator. And the first thing that happens is we're given a little quiz here to see what is the indication for a cardiac defibrillator. And we're offered sudden cardiac death. Not quite. You have to be a survivor. You have to survive sudden cardiac death in patients with cardiomyopathy. The next possibility is a patient post-myocardial infarction with an ejection fraction of less than 35%. Then we're given the possibility of a patient with spontaneous type 1 Brugada syndrome. And finally, we're given the possibility of a patient with recent onset tachycardic myopathy with an ejection fraction of less than 25%. I happen to know the answer, and it's the patient that has an ejection fraction of less than 25%. Because the other syndromes can be dealt with the beta blockers or other treatments and have a prognosis that is not helped by having a cardiac defibrillator. So that's the correct answer. But at any rate, here's the story. So this is a 17-year-old that obviously must have an ejection fraction of more than 25%, since he's a competitive swimmer. So he's swimming in salt water and develops an episode of ventricular flutter, which is shown here on this electrocardiogram. So here's the CKG. Here suddenly he develops fast ventricular tachycardia, or actually ventricular flutter. So his device shocks him, and it doesn't help. Then he develops ventricular fibrillation. So this is fairly deadly. So then he somehow gets out of the water, and out of the water, his defibrillator shocks him again. And suddenly, a rhythm, a life-sustainable rhythm, is accomplished. So this report suggests that if you're in salt water, your defibrillator might not work. And the discussants give reasons why that might occur. So the patient was fit, he had little subcutaneous fat, the salinity of the water might have facilitated a short circuit. I'm not sure why, because the device is subcutaneous. But at any rate, as this electrocardiogram shows, don't know for certain, but the first shock didn't work. He developed atrial fibrillation and had to be shocked again until sinus rhythm was restored. Then I tried to figure out from this bipolar lead in the defibrillator what the basis of his problem might be. And if this is a lead 2, I'm not certain, but I guess he might have had Brugada syndrome, and maybe should have been treated with the beta blocker. I don't know. The information wasn't given. So now we'll move to this week's New England Journal. And here we see a 29-year-old man who has aplastic anemia, and he's been treated with cyclosporin, and suddenly he has a 4-day history of fever, cough, and difficulty breathing at rest. And then he develops this rash that I can't see very well, and I don't know what it is, but it seems to be centrifugal in nature. That means his chest is involved. We aren't shown his extremities or his face or his hands, but what's the information given here, and I can't really appreciate that from this picture, is that this rash consists of vesicles. That means small blisters. Vesicles are small blisters. Skin vesicles are small blisters. Then he gets pustules, and these vesicles become encrusted. Then we're given a differential diagnosis of 5 things. Now, eosinophilic granulomatosis with polyangiitis does not cause blisters. Neither does DIC. Neither does drug-induced hypersensitivity syndrome might, but there the blisters are much larger. And immune thrombocytopenic purpura also doesn't cause blisters. So here we have an immunosuppressed adult that has a blister-related acute illness, and I would pick chickenpox, varicella, and maybe he wasn't vaccinated. Children are now vaccinated against chickenpox, and the history is given, but we'll find out about that next week. Now, the first topic of the New England Journal concerns this drug, of which I'd never heard, but we can see here it's got a steroid nucleus here, basically, and then this peculiar side chain. This drug is called Sage 217. I didn't know this, but this drug is a modulator of the GABA-A receptor. So if it modulates the GABA-A receptor, we might think that it might have some utility in depression. And indeed, that was the hypothesis that was tested in this study. These are depressed patients receiving the usual treatments for depression, and then they received on top Sage 217 compared to placebo. Now, depression is fairly difficult to measure, so there are evaluation scores to judge depression in these patients. Maybe they were depressed because they were overweight, because they were in both groups. So these are middle-aged patients with various ethnic backgrounds that have a long history of previous depression that are randomized to Sage 217 or placebo. Now, what we see here is that their HAM-D score, that's a depression score, looked better with Sage 217 compared to placebo. And a sustained reduction in this score of 50% was also better in the Sage 217 group compared to placebo group. And the patients that had a substantial response was also better in the Sage 217 group. Of course, we're interested in side effects, and the most common side effects were headache, dizzy, nausea, and somnolence. But at least increased appetite was not one of the side effects. So that looks pretty good. So in conclusion, Sage 27 might be an additional drug that psychiatrists can use in their armamentarium to treat depressed patients. Now, the next topic at the New England Journal was our varicose veins. Superficial varicose veins are pretty common, and they result from degeneration of the valves that we have in our lower extremities to keep the blood moving forward even when we're in a standing position. I don't know why this individual is standing in a pool of water, but here's an example of varicose veins. Now, since the 1950s, these have been treated surgically, at least after the surgeon determines that the deep veins of the lower extremity are competent, and that's done by clinical tests and now probably by imaging. If those veins are competent, then the previous treatment used to be stripping these superficial varicose veins so that the pain associated with them and ulcer development and other symptoms are ameliorated. Now, there are more modern treatments of this condition in addition to surgical ablation, and one of them concerns an endovenous laser treatment to ablate these veins. And then there's another endovenous treatment that involves the application of a foam so that these veins thrombose and are sclerosed and disappear. Now, the question in this complicated study that we see here is which one of these treatments is better? So comparisons were made in people with varicose veins that required laser ablation, foam sclerotherapy, or the conventional operation. So there are a fairly large number of patients here, and their extremities are shown here and the veins that were involved, and deep vein reflux. I hope all of them had functional deep veins, and all of that was assessed here. So we see here an evaluation, surgery versus laser, and then laser versus sclerotherapy, and surgery versus foam. And basically what this complicated table evaluates here is, first of all, quality of life. What did the patients think? And then what was their physical assessment in terms of whether or not the treatment was effective? And both were assessed with various scales that doctors that treat varicose veins apply in these patients. Basically, what we see was the sclerotherapy and the laser sclerotherapy beat surgery, and laser ablation beat the foam. So laser ablation appears best. Then a Markov model was used to see what's the cost effectiveness of these treatments. And what we see here is that laser treatment was the most cost effective. That means that the veins went away and the patients were happy and the surgeons were happy. And that beat foam sclerotherapy, and it also beat surgery. The foam sclerotherapy seemed to have some problems later on, and also in terms of willingness to pay per quality. I'll let you enjoy that on your own.
Nur weil ich mal den linken Unterschenkel morgens, deswegen erzähle ich
So that was the result of that study. Now,
ja, ich wusste gar nicht, dass es Lasertherapie gibt bis eben.
The next paper in the New England Journal involved the enzyme pyruvate kinase. And for those of you whose biochemistry was 50 years ago, you may want to review this scheme, how we metabolize glucose. And we metabolize glucose to fructose 6-phosphate, and then to basically a phosphoenol pyruvate, and then phosphoenol pyruvate is changed to pyruvate via the enzyme pyruvate kinase, and then pyruvate is stuck in the tricarboxylic acid cycle so that we generate lots of ATP. Now, there are many mutations in pyruvate kinase, and these mutations bother erythrocytes most of all, because once these cells are formed, they're sent into the periphery, and they have a life expectancy of 120 days. Now, you'll recall that erythrocytes have no cell nucleus, so they can't make any more pyruvate kinase. So if there are mutations in pyruvate kinase, erythrocytes are the cells that suffer. And what patients with pyruvate kinase mutations get is hemolytic anemia and spiculated erythrocytes, as shown in this peripheral smear. Now, presumably, pyruvate kinase mutations occurred because of malaria, because of the same way that glucose 6-phosphate dehydrogenase mutations occurred. But at any rate, these mutations are relatively common worldwide, and the question is how to help these patients. So a drug was developed, metapivate, and metapivate is an oral small molecule allosteric activator of pyruvate kinase in red cells. This means that with this drug, the tired pyruvate kinase that these patients have might be more active so that these erythrocytes can produce ATP and don't hemolyze. Now, there's a broad spectrum of pyruvate kinase mutations. Some of them are relatively mild, and others are severe. So we might imagine that patients that have still some pretty good residual pyruvate kinase activity are going to profit more from metapivate than patients that have severe pyruvate kinase problems. And the first question, of course, is adverse events. And the adverse events were headache, insomnia, and nausea. Okay, those are relatively tolerable, in my view, as a non-hematologist. And what we see here is that the increase in hemoglobin of these patients with these pyruvate kinase mutations was pretty impressive, from one of a hemoglobin of 8.5 to 12.5. And the reticulocyte counts in these patients dropped because they hemolyzed less. And their indirect bilirubin levels dropped, and their haptoglobin levels improved. So this is pretty good evidence that if you have a patient with a pyruvate kinase deficiency that has hemolytic anemia, this drug is going to help. And found that this study was pretty impressive. Now the next topic in the New England Journal is alveolar proteinosis. And that condition involves this collection of this proteinaceous material inside your alveoli, implying that the surfactant mechanisms of removal are disturbed. And this disease, thank goodness, is relatively uncommon. And from the looks of this chest x-ray and this CT, you might imagine that patients with this condition are hypoxemic. Now, the heroic treatment that's applied is bronchoalveolar lavage, which does make these patients better, but has major problems. Now, the problem can be caused on a genetic basis involving mutations in surfactant protein B, but it can also involve problems with GM-CSF. GM-CSF is pivotal to surfactant maintenance, and there are autoimmune diseases involving antibodies to GM-CSF that result in alveolar proteinosis. So many patients have these autoantibodies against GM-CSF. So the idea here is to give the patients their GM-CSF back. And ideally, we would like to get it to where the problem is. And so this is a study of inhaled GM-CSF in patients with alveolar proteinosis. So thank goodness this condition isn't too common. So these patients, there's a placebo group and an inhaled GM-CSF group in this particular study. Now what we see here is a modest decrease in the alveolar arterial oxygen gradient. I'm sure you all remember my lectures on the alveolar gas equation, and that's how this gradient was calculated. Then there was also evaluation of the CT, which can be quantitated in terms of how much residual infiltrate there is in both lungs. Here's an example of a patient that got better. So these are the two endpoints. And this is a fairly complicated, tedious table, but basically what the study showed is there was an improvement in alveolar to arterial oxygen gradient, but it was fairly trivial. And the CTs got better, but not too much, and the patients felt about the same. But basically, although these differences are statistically significant, I'm not certain that they're of any clinical value. So inhaled GM-CSF had a significant but very modest effect on the alveolar arterial oxygen gradient, and the CTs got somewhat better, but the patients didn't feel any different. Now the review in the New England Journal involves immune thrombocytopenic purpura, or ITP, and this is an autoimmune disease. It's not too uncommon, and it was previously treated with corticosteroids, and if those didn't help, we subjected the patients to splenectomy. But the results were not too satisfactory. So this vignette here is a 72-year-old woman who receives a Pixabon for atrial fibrillation and suddenly shows up with a hemoglobin of 8.5, has some sort of gastrointestinal bleeding, I suppose, and has a platelet count of 2,000. White count's okay. And the question is, what's going on in this patient and what should we do? So the clinical messages are People with ITP, the diagnosis is established in patients that have a platelet count less than 100,000 in whom no other causes of thrombocytopenia can be found. And these patients receive glucocorticoids and now intravenous immunoglobulins. They receive platelet transfusions if they need them, and glucocorticoids are first-line treatment, and if that doesn't work, you might have guessed, give these people rituximab. And splenectomy has been assigned to a second-line treatment because splenectomy in and of itself causes substantial problems of a different nature. So here's a table involving the differential diagnosis of ITP, and here are all the other causes of thrombocytopenia in the world listed here, which are in the differential diagnosis. So you have to rule out all those things before you can diagnose ITP. And ITP is an antibody-mediated disease, and so we might imagine that macrophages, T cells, and B cells are involved to produce these antibodies, and that the antibodies are directed against some sort of epitope on platelets. And that's the mechanism of how this might happen. So here's some examples in this peripheral smear. If in a standard peripheral smear, you would expect to see 1 platelet per high-powered field. And if you can't find that platelet per high-powered field, that patient probably has thrombocytopenia. And here's some clumping of platelets that have just been released by this big megakaryocyte that we see here on the right. So what do we give these patients? Prednisone or prednisolone, dexamethasone might also work, immunoglobulins, and then there's a stimulator of platelet formation, I can't even pronounce this drug, but here it is, eltrombog. And then there are immune modulators, rituximab. There's also an inhibitor of the psych-tyrosine kinase that I saw on here, and other immunosuppressives that can be given these patients, and splenectomy has been assigned a secondary role. So that's all outlined in this important review because this condition is not that uncommon and physicians should know something about ITP. So this inhibitor of the spleen tyrosine kinase, the psych inhibitor, is called fostamatinib. So you can stick that in your memory repository. Then the patient in the New England Journal bothered me quite a bit. This is a 54-year-old Korean man who develops back pain, and he gets non-steroidal anti-inflammatory drugs. They don't help too much. And so he comes to his doctor on various occasions. He has some other problems. He's a smoker, and he gets various drugs. And if we look at his lab work here, he's got a hemoglobin of 10, and his platelet count's okay, and ferritin levels doesn't explain the anemia, and his transferrin level is 192, and his saturation is only 3%. Looks like some inflammation going on here, and his glycated hemoglobin level is 7.5. Then here's some pictures. This is an MRI, and what we see here is that there's evidence of vertebral erosion and disc disease, although the disc isn't entirely destroyed. The discs are inflamed, but they're not completely destroyed. But what we see here is bony erosions below this discitis, if you so will. And in the next MRI, this is his sacroiliac joint. And what we see here in this particular example is there's an evidence of sacroiliitis. Now, the misleading problems in this report is he's HLA antigen B27 negative, which is, and 95% or more of patients with sacroiliitis, Morbus Bechterew in German, or spondylosing ankylosing are HLA B27 positive. This patient is not. But his TB skin test and tuberculosis is also in the differential diagnosis, although in tuberculosis the disc is generally completely destroyed, which was not the case here. So his TB test was positive. So his doctors tried to make a diagnosis of TB. We're not given too much additional information on that, But at any rate, they treat him for tuberculosis for 4.5 months and he doesn't get any better. They do a GI workup and he's got some chronic mild gastritis, and so they alter his pain medication a little bit, and then they decide that he probably has ankylosing spondylitis. So they treat him with the TNF antagonist, this etanercept, which is a fusion protein. That results in an improvement in his symptoms. But then the patient develops a series of oral ulcers, and they're shown here, and they look pretty ghastly. These are aphthous ulcers, and they are very uncomfortable. And additional imaging is done, and he's got terminal ileal wall and thickening, terminal ileum thickening, and he's got these bilateral erosions of his sacroiliac joint that suggested that he might have ankylosing spondylitis. A bunch of other studies are done, but eventually what happens to this patient is before he can be subjected to an outpatient colonoscopy to explain this terminal ileal thickening, he develops severe difficulty swallowing, sudden abdominal pain, and bloody stools. So he comes into the hospital and is subjected to an exploratory laparotomy, and there the diagnosis is made. And here's his terminal ileum that shows this massive inflammation. And basically what he has is a very atypical form of Crohn's disease. So he has terminal ileitis, although he really doesn't have the usual symptoms that we associate with Crohn's disease, aside from the aphthous ulcers, which are fairly common. And these joint complaints, which occur in Crohn's disease but aren't that typical, and then he's treated for Crohn's disease and finally gets better. So then we move to the Lancet, and I think this next study is wonderful. Patients that have colon cancer or some other severe diverticulitis, or the patients that have to be subjected to colectomy, always, in my generation, always received a fairly aggressive bowel preparation before they were subjected to colectomy. Now this bowel preparation, in addition to antibiotics, neomycin, metronidazole, etc., completely obliterates the microbiome that could be bad for you. But that's the standard treatment. So the patients that receive colectomy are treated with this mechanical, and mechanical means enemas until you can't stand it anymore, and oral antibiotic bowel preparation. And the surgeons, British surgeons, ask, is this necessary? So the patients that needed colectomy for various reasons, colon cancer was the most common reason, were randomized to mechanical and oral bowel preparations or no bowel preparation. And here's a tabular demonstration of the data, and the outcomes were no different. No different. And surgical complications were also no different. So this study suggests that this mechanical and oral antibiotic bowel preparation may be entirely unnecessary, and perhaps we're doing the patients an injury instead of doing them a favor. Now, the reviews in Lancet were acute liver failure, which is always a good topic. And in the UK, paracetamol, or acetaminophen, is the most common cause of acute liver failure. I would think that, and these patients overdose themselves. And this is given to treat pain. That might be one good reason to take this drug off the market. And these other causes of acute liver failure, Wilson's disease, Budd-Chiari syndrome, pregnancy, and other things are considerably less common. That's the first message. Then what the biopsies look like depends on the underlying problem. And brain edema and whatever else happens in acute liver failure, you can review that on your own. But the causes, paracetamol, it's enough to make you ill, even if you don't take paracetamol. The next review is pemphigus. This is a debilitating, blistering skin disease, and it's caused by antibodies against desmoglians, desmoglian 1 and 3. And we know that now, and so this disease should be treated accordingly. And these patients develop more common in women. They also get hepatic encephalopathy. They have liver enzymes. Their bilirubins are elevated, and etc. And they have other manifestations, including oral problems. And if you do a skin biopsy and do immunofluorescence, you can detect the antibodies against these two desmoglians, 1 and 3. So that's pemphigus. And it's really, this is an awful disease, and there are models of this condition. And in vivo tests involving, there's a murine test, but what we need to determine is antibodies against desmoglians. So that's the story on pemphigus. And the steroids, yes, I can imagine that rituximab plays a role here. And the intravenous immunoglobulins, here's rituximab. And so now we have more options to treat these poor patients with this debilitating skin disease. We'll finally close after 2 weeks of these journals. And here are two monozygotic twins. And they have this area of alopecia on the back of their heads. And this is called aplasia cutis congenita. And if both twins have it, and you'll recall that they share their entire genomes, then this might have a genetic cause. And the skin defect can be confused with other causes of hair loss, but since both twins, two lovely redheads, have exactly the same area of alopecia, we can look to see what genes are responsible for that. And I learned about the BMS1 gene, which is located on chromosome 10, and apparently this gene encodes a ribosome assembly protein, and how that causes this syndrome, I have no idea. Then we'll close with the NICE guidelines. NICE is the National Institute for Health and Clinical Excellence in the UK. You'll recall that the Americans have recently changed the definition of hypertension, the most common risk factor in the world, and lowered it from 140 to over 90 to 130 over 80, which increased the number of hypertensive persons in the United States by about 20 million. Now, the British are a little more conservative. So they stuck with their old definition, although they altered their risk score to 10%. I don't know exactly what that means, but I thought I'd tell you about it anyway. That's it for this week. Join me next week for another thrilling episode of Clinical Journal Club.